Good afternoon and welcome to today's panel conversation, Exploring Health Disparities in Minority Family Caregivers. My name is Juliana Valencia. I am the supervisor for the Caregiver and Supportive Services Unit with Fairfax Area Agency on Aging. Now, a few housekeeping items before we begin today's session. So this presentation is going to be recorded, and you are going to get a recording of this presentation a week from today. Now, in addition, you will be getting the slides with the recording. And if you have any questions during today's presentation, please use our Q&A button. We are going to be having a Q&A session, and we would love to hear your questions. Also, we have enabled closed captioning. So if you need it, just make sure you click on the closed captioning icon, which is at the bottom of your Zoom window. Also, at the end of today's presentation, there is going to be a quick survey. If you could take a moment to answer those questions, it will really help us provide topics that are important to you. Now, many of us have often wondered about what causes some people to age better than others, especially family caregivers and older adults. Now, research suggests that many complex factors can affect the health and the quality of life of family caregivers and older adults. And understanding how some of these environmental, social, and cultural factors interact and create health disparities is crucial in supporting and improving the quality of life in family caregivers and older adults, and of course, adults with disabilities. To understand and have a conversation about it, we have invited Dr. Bei Wu, who is the co-director of the New York University NYU Aging Incubator. She holds the position of Dean's Professor in Global Health at NYU, as well as Vice Dean and Research Affiliate Professor at the Ashman Department of Periodontology and Implant Dentistry. In addition, we have invited Dr. Jerry Johnson, who is a medical doctor and an emeritus professor of medicine at the University of Pennsylvania. He is the former president of the American Geriatrics Society, former chair of the clinical medicine section of the Gerontological Society of America, and is currently the vice chair of the Health in Aging Foundation, which is the public outreach arm of the American Geriatrics Society. Lastly, we have invited Dr. Carolyn Mendez-Luck, who holds a PhD and master's in public health. She is an associate professor of health management and policy at Oregon State University's College of Public Health and Human Sciences. So thank you so much to our panelists who are here with us, and I would like to invite Dr. Bei Wu to begin with her presentation.
Thank you, Juliani, for the introduction. It is great to have the chance to share our research findings with the audience. So today, my topic is particularly focused on Asian American dementia caregivers. Think about some challenges and also explore intervention strategies. So Asian Americans are the fastest growing minority groups in the United States. Among Asian Americans, Chinese is the largest, and Korean is the fourth largest group of Asian Americans. So based on recent statistics, there are nearly 5.4 million Chinese Americans, and among them, more than 60% are foreign-born. And for the Korean Americans, it's close to 1.9 million Korean Americans in the United States. So certainly there's the huge disparities within Asian populations, probably one of the most heterogeneous group of the population in the US. There's significant income disparities, and also think about language proficiencies. Only 57% of Chinese adults and 61% of Korean adults have high English proficiencies. So among Chinese older adults, based on some statistics, that close to 3/4 of Chinese older adults have limited English proficiency. So this is significant challenges facing these, and particularly facing immigrant populations. So here is a stats. Think about the population growth of Asian populations. Is that in New Jersey and in New York City, where I'm at NYC, that you clearly see that think about population growth. That the Asian population has the highest growth than other minority populations overall, that compared to Hispanics and the Blacks overall. So, but also think about this kind of model minority myths and the health disparities among US Asian populations is very significant. Think about that. We did a study, just have a paper published at GSA Population Public Policy and Aging Report. We, based on our own data analysis, we found that within Asian population, that for those individuals have a high income versus those individuals has a lower income, that the health disparities is the most significant in comparison to other racial minority groups, that in terms of cognitive function, in terms of mental depressive symptoms, as well as physical functioning, that for the health disparities is most significant in comparison to high income versus low income in Asian population. So Asian Americans, there's and the caregivers for relatives with Alzheimer's disease and the related dementias, we call this ADRD, that certainly there's a lack of awareness of early symptoms of ADRD and the reluctance of seeking help. So this is basically, it is a quite consistent kind of a phenomenon that we did study even more than 20 years ago, that found a very strong stigma in Asian population towards Alzheimer's disease and the dementia. And recently that we did a study even this year in New York City, we still found that this is the strong stigma towards Alzheimer's disease. So 20 some years that apart, that the sense of stigma towards dementia has not been significantly kind of decreased, the level of stigma. So in Chinese character, that the dementia, that means craziness. So there's of course, there's a move towards kind of changing the term of using in Chinese term describe dementia. And also limited knowledge about Alzheimer's disease and the dementia, that many Asian populations think about dementia as a normal part of aging. So, and also that think about cultural values affect stress, and the copings among caregivers is very complex. Chinese dementia caregivers feel compelled to adhere to ethnic norms of filial piety that value intergenerational reciprocity. That also that there's a lot of family conflict that related to Alzheimer's disease caregivers is likely to occur due to a different perception of diagnosis, as well as treatment for the disease, and also in terms of family obligations and the caring practices. There's a lot of family conflict within the Asian populations as well. So here currently we are funded by National Institute of Health to conduct this research project. Is conduct a 2-arm randomized control trial to test the efficacy of NYU caregiving intervention that enhances support that in reducing health risk for cardiometabolic diseases among all the Chinese and the Korean American adults caring for relatives with dementia. Because what we want to do is to, this NYU caregiving intervention has been actually developed by Mary Middleman many years ago, but this kind of intervention has not been adapted to Asian American population. So we use this kind of approach to adapt the intervention protocol to Chinese and Korean dementia caregivers, and particularly targeting for those with chronic diseases, because dementia caregivers, many of them have chronic diseases themselves. So how to actually these kind of interventions to reduce the health risk for these Asian American caregivers. So this is the kind of an ongoing study that our team is conducting. So for our design included two groups that within each ethnic groups. Control groups is the strategy combine online group chat and on-call that brief telephone consultations. Treatment groups that include 6 sessions of individual and family counseling, as well as local support group participation. And additionally is also online group chat, the telephone consultation in a more kind of flexible format that tailor to each caregiver families. So the duration of intervention is 6 months active intervention and 6 months maintenance. So overall, it's a kind of a 1-year period for this intervention. So we have kind of these are the kind of treatment groups. So we have in-home visits as well as the telephone consultation, as well as online kind of group chatting, this kind of format. So that another project that I want to share with the group is we just recently this year we completed the survey among Chinese caregivers' attitude towards tube feeding for persons with dementia. So here that feeding tubes can have a lot of risks in terms of bleeding, infection, skin irritation, or leaking around the tube, and including nausea, vomiting, and diarrhea. And many kind of risk involved in tube feeding. So, but the question is that whether certainly there's some kind of the advantage of tube feeding, because some people, particularly at the advanced stage of dementia, people have the tendency to refuse to eat. So they're actually most likely these individuals will have a risk of malnutrition. But on the other hand, there's a lot of risk factors that risk involved in tube feeding. So the question becomes whether caregivers know the risks. So what are dementia caregivers' attitudes toward tube feeding? And how can healthcare professionals help caregivers to make decisions based on our literature review that Chinese American dementia caregivers has a very high use of tube feeding, close to 75% of the dementia caregivers that actually allow kind of a tube feeding for persons for their care recipients, versus in general population, this is that percentage close to like 20% or so. So it's a huge kind of differences between these Chinese Americans use tube feeding versus general population has a much less prevalent of using tube feeding. So our study is trying to look at what Chinese dementia caregivers know the risk about tube feeding. So to address this knowledge gap, that our study was trying to characterize caregivers' attitudes toward tube feeding based on survey conducted among Chinese American dementia caregivers in New York City, and also examined the decision-making on feeding options in a hypothesized scenario. We gave people the kind of hypothesis scenario and asked them to provide their answer to this kind of scenario. And also the goal of care, knowledge of tube feeding, perception of main purposes for using feeding tubes, decision-making style, perceptions concerning patients' wishes, and views towards food at the end of life, and the factors associated with hand feedings as well. So here is some kind of brief results from the study that when you look at this, that close to 76% of the individuals either kind of report to say that they prefer a tube feeding or not sure about a tube feeding. And only 24% say they prefer kind of hand feeding. And the goal of care, they prefer, 94% prefer to relieve pain and discomfort as much as possible. But only 16% of caregivers that had a discussion with providers on the tube feeding kind of options. So very limited kind of discussions that kind of happened during these kind of about tube feeding options. So when you look at these kind of main reasons for tube feedings, that 81% say that the purpose of tube feeding is prolong life. And the next is 56% say the purpose is to prevent aspiration. So that's the kind of, and 65% say not to feel, that the care recipient not to feel hungry or thirsty. So in terms of with the family, who should make a decision on tube feeding? So when you look at that, this option, that 56% reported that caregivers or other family members that equally should make a tube feeding decision. That when people respond to who do you think should make a decision on tube feeding, that more than half of the respondent reported that either the provider or the families that equally can make a decision on tube feeding, most frequently to answer that. So, and the patient's wishes, if you look at patient's wishes, is a few that the percentage, and 38% say patient's wishes is the most important one in decision-making on tube feeding. So family certainly plays a very important role. Family's decision in that sense is very strong in that. So when you look at the results, that knowledge was significantly, knowledge about tube feeding, knowledge about hand feeding was significantly associated with the selection of hand feeding, versus the expression of patients' wishes was associated with the selection of hand feeding. So if it's for caregivers that who honors that the wishes of patients and have discussion with patients earlier, that was more associated with the selection of the hand feeding instead of tube feeding. So overall, that we can see the considerable proportion of caregivers, that 67% of caregivers will choose tube feeding in the hypothesized scenario. The knowledge about tube feeding and the knowing patients express wishes regarding tube feeding were associated with a higher likelihood of preferences towards hand feeding among Chinese American dementia caregivers. So that certainly this is a lot of kind of discussion. This study found similar kind of results from conducting Hong Kong and Taiwan, suggest that more than 50% of Chinese with advanced dementia in nursing homes were tube fed. So it's a quite kind of consistent kind of findings. So that why a large proportion of Asian American caregivers choose tube feeding, that certainly one potential reason is having poor knowledge about tube feeding. The fewer caregivers knowing patients express the wishes regarding tube feeding. So advanced kind of care planning was very limited in proportion of individuals have advanced care planning. And the family decision-making, the filial piety may play an important role in decision-making about tube feeding. So overall, that was that we found that the majority of Chinese dementia caregivers choose tube feeding or were unsure whether to choose hand feeding or tube feeding. knowledge of that tube feeding and the knowledge about patient expression, which are so important in the selection of in the life of decision making. Certainly that we need to think about family decision making and the families, filial piety as a culture that valued by Chinese American dementia caregivers. So we currently think our findings underscore that clearly that improving knowledge about tube feeding and the advanced care planning engagement is very important in end of life decision making, and incorporate the Chinese unique culture are crucial for improving decision making regarding feed options in Chinese American populations. So due to limited time, I'm just going to stop here. Thank you very much for listening. I look forward to our question and answer section. Thank you.
Thank you so much, Dr. Wu. And my next presenter is going to be Dr. Jerry Johnson. Please go ahead and take it away. Thank you.
Yes, thank you and good morning. I'm going to talk about caregiving of African Americans with serious chronic illnesses. My objectives are influenced by three roles in my own personal experiences. That of being a caregiver myself for parents and step parents, that have been an investigator and educator as a physician, and also those experiences of caring for patients. So my objectives are to share with you both caregivers and providers with the goal, particularly for caregivers, of helping you appreciate the necessity of self-care and knowing some steps relevant to improving your care. For caregivers, as a consequence of this presentation, I'd like to enhance your knowledge and skills that will assist you in your caregiving roles. And for caregivers and providers, enhance your ability to communicate effectively, both within families and between families and recipients. I'm going to refer to the patients as recipients, particularly the ability to negotiate cultural beliefs. There is a high burden of disease independent of caregiving duties in the African American population. I think that's similar to what you just heard in the previous presentation. African Americans tend to persist in trying to provide in-home care. There's a strong aversion to nursing facility care. They're less likely to use paid resources, and the consequences of caregiving, consistent with what was said in the last presentation, can sometimes lead to unfortunate mental health and physical health problems, including the increased likelihood of death. So self-care is critical for family caregivers. And one of the major take-home points from this presentation that I would like all the family caregivers to be mindful of are steps that they can take to improve their self-care, including establishing a regular sleep pattern, plan regular physical activity. The third bullet, seek and accepting help, is of critical importance. I find that male caregivers, who may comprise as many as 30 or 40% in the African American population, are reluctant to seek help and find themselves isolated. Caregivers need to maintain their own health visits. Some persons find beneficial meditation, breathing exercises, and increasing your knowledge and skills in your roles as caregiver is one way of improving your health. hence the focus on your education. What do you need to know, and what skills do you need to be attentive to? The caregiver roles are multiple. I think many family caregivers are not attuned to the depth and breadth of what they'll be asked to do. They include emotional support, of course, hands-on care, but also being a decision maker, being a spokesperson and translator, being an advocate and care coordinator, and being a family peacemaker and mediator. The last one can add significant stress to the role of the primary caregiver. In referring to knowledge, I am asking that caregivers be attentive to the principal disease that the recipient may have, as well as the other diseases. Many of these persons, the recipients, are going to be in the older adult category and are going to have more than one disease that's impacting their life. So knowing the symptoms and at least understanding the basic rationale for management is important. There needs to be an understanding of what we mean by a serious illness, and knowledge of community resources like the Fairfax Area on Agency is important also. So what makes a serious illness serious? One, for purposes of this discussion, it's a chronic illness. It's persistent. And its prognosis is one that has a high likelihood of increasing disability or death or both. So that is what I'm referring to in referring to a serious illness. Having a framework for how one is thinking about the big picture is important for caregivers. And I would draw your attention and health professionals to 3 points. One is that this is something I learned from a chaplain and a pastor who was part of one of my research teams, that caregivers should think of themselves as accompanying the recipient of care on a journey. It's the recipient's journey. Both health professionals and caregivers should think about anticipatory guidance related to particular issues prior to a crisis. The previous presentation talked about feeding tubes and needing to make decisions about feeding tubes. I found it helpful as a clinician to start that discussion with family members about a feeding tube a year or more in advance, instead of waiting until the crisis has occurred. And with all parties, both health professionals and caregivers, one way of framing what we're trying to accomplish with a patient is to use the term a good life, to focus on a good life. This is in contrast to a long life, or in contrast to a good death, which come up in the literature. But I have come to recognize that focusing and framing discussions around what is a good life for the recipient is a beneficial way to make progress. What skills do you need to be adept at? I've categorized them as performance skills, others that are performance and observational, and then communication skills. The performance skills I won't say much about, except to alert you to the fact that behavioral care management can be a significant challenge in persons with dementia. But what I want to focus on are the performance and observational skills and the communication skills. The performance skills I'm going to talk about in 2 categories: what in geriatrics we call function or functional status, and what the John A. Hartford Foundation started 10 years ago calling the 4 M's. So first, functional status in relation to what you need to do. And what I'm asking caregivers to think about is developing a capacity to monitor and report on activities of daily living. In geriatrics, we talk about those in two categories, basic and intermediate. These activities of daily living are functional, are relevant no matter what the chronic disease is that is being addressed. Bathing, dressing, grooming, transferring, and the intermediate activities you can see before you. The capacity to monitor and report on the 4 M's refers to attention to mentation, mobility, medication, and what matters. So in thinking about mentation, and this is an observational skill, you should be observing the person's memory capacity, orientation, what we call attention, language skills, and visual spatial skills. Mobility assessment, I find to be a real challenge for a lot of caregivers who don't realize the significant fall risk of a person who has an unsteady gait or who has poor balance, simply because much of the time it looks like they're okay, but it's clear if you're observing closely that sometimes they're unsteady. So be mindful of that. And then the medication monitoring is more straightforward. Of all the 4 M's, what matters, or the goals of care, is perhaps the most important. The issue is what matters to the recipient and the caregiver, if the caregiver is speaking on behalf of the recipient. Not what is the matter. What is the matter is more of a medical framework. What's the disease? What's the problem? But what matters is not encompassing the treatment and the diagnostic measures, which are more like pathways to help us accomplish what matters. So what matters are the goals, and communications are central to effectively discussing those. In this slide, to further elucidate what I mean by the distinction between goals versus treatments, I'm showing two categories, treatments, medication, surgery, feeding tubes, hospitalization. But the point is asking oneself what goals are most important to the recipient, and the caregiver's knowledge and history with the recipient will go a long way toward understanding what those goals may be. And I show examples of those goals that come up quite often in care. There are some challenges, though, to elucidating and eliciting exactly what matters most. One of the main challenges that I've already alluded to, persons confuse goals with treatment options. Also, recipients and caregivers have multiple goals. And sometimes recipients and their caregivers do not recognize that the goals and the treatment decisions may contradict one another. They may be contrary to one another. For example, a feeding tube may actually, as was pointed out in the previous presentation, may cause more stress, may cause harm, and instead of bringing comfort. So health professionals need to help make that connection. The communications are the bridge to resolving some of these dilemmas. And there are multiple communication pathways. So we think about the main family caregiver near the bottom of this slide. That person is interacting and communicating with the main health provider, with the recipient or the patient, with other family caregivers. And so there are these multiple pathways of communication that can sometimes lead to mixed messaging and add to confusion. But the factors influencing communication can be categorized in the following way. And as health professionals, I think we can, if we recognize these different subsets and categories, we can focus on trying to make communication more effective. The simplest is misinformation or just lack of information. It's starting with the meaning of medical terms, but there are also cultural factors like distrust or mistrust, one of the outcomes of distrust and mistrust in the African American community is a belief that the opposite of having been deprived of health care is to get more, that more is better. And then there are beliefs and attitudes, whether spiritual faith beliefs or alternative medicine beliefs, that must be negotiated. So they need to be understood and negotiating. And health literacy and family structure dynamics also come into play. A few years ago, I came across this very helpful manuscript, which can be downloaded from the purchase on the internet. It's called "Don't Sing Songs to a Heavy Heart." And for African Americans, many of whom are Christian, I think this manuscript would be instructive and would be useful, because many caregivers are asking, what should I say to a loved one who has a serious illness that has advanced, for example, to the point where it's now a life-threatening illness? What should I say? How should I talk to them? And the authors entitled this "Don't Sing Songs to a Heavy Heart," because to make the point that the persistent cheerleading approach is not as constructive and helpful as one might think it should be, and it's not really justified just because one is of Christian faith either. So what I show you is a table that I extracted from the manuscript with two columns, comments that are less desirable versus more desirable. For example, saying it's God's will that you're suffering and in pain is not as helpful as saying, I am so sorry. Or saying the second row, sharing a personal example. I see this quite often, where the caregiver or friend of the family talks about what happened in his or her life or with a friend or someone else, in contrast to the more desirable approach of saying, bring me up to date, what is happening in your life? And that's a reflection of the latter, to bring me up to date what's happening in your life. It's an example of going on the journey with the person instead of the opposite. The last row, where you see the yellow highlight, listening and cheerleading, are my additions to the table that wasn't actually in their manuscript. I'm making a distinction between listening, which is one of the most important forms of communication, versus their cheerleading. I like to start with broad questions. When you think about the future of the recipient, what is important in trying to get at goals and values, and here again is where a family caregiver can be very important to health providers in giving insight on what gives the recipient's life meaning. That's not a single question, that's an inquiry that has to take place over time. So, for example, for my father-in-law who died at age 103 about a year and a half ago, what gave his life meaning most was being independent. What gave my mother's life meaning most was service to the family. So that is something that a family caregiver needs to share with the healthcare team. We talked about the significance of faith and spiritual beliefs. Although African Americans, a high proportion of African Americans are religious and even Christian, and that raises some concern as to whether they think faith and spiritual beliefs are contrary, for example, to hospice. We found that over 80% of 100 church leaders in a study that we published, and that's included in references at the end of this presentation, that these church leaders actually believe that hospice is consistent with their faith and spiritual beliefs. But one can inquire about the significance, and should inquire about the significance of spiritual beliefs to the illness and treatment options, And health professionals should also enlist the assistance of chaplains. So to summarize what we discussed, framing the issue, first recognizing the multiple caregiver roles, attending to self-care is critical, framing the decision, particularly to focus on a good life, and then enhancing knowledge and skills. And I will leave it to you to look over some of the references here, which I think can also contribute to reducing stress among the caregivers, because you would have a better understanding of how one can frame, can think about, and can meet the challenges of caregiving. And I'll stop there. Thank you.
Thank you so much, Dr. Johnson. That was a great presentation. Now I would like to invite Dr. Carolyn Mendez-Luck to continue with her presentation.
Okay, so I hope you can all see my presentation. Good afternoon and greetings from the Pacific Northwest. I want to thank Juliana for the opportunity to join the conversation today. In my presentation, you might notice that I will use the term Latino, Hispanic, or Mexican, but I fully recognize that Latinos refer to diverse groups with varied historical and geopolitical backgrounds and cultures. So for my presentation, I hope to offer a balanced view of challenges and opportunities for Latino caregivers. And I will first address some key cultural beliefs that may frame caregiving for some Latino caregivers. I'll touch on the federal government's potential response to caregiving with an equity lens to those policies. I'll briefly highlight what the Aging Network and caregivers can do in the meantime as Congress addresses solutions for the long term. And then I'll conclude with my own take on the caregiving landscape in the future for Latinos and all caregivers. So I want to start with the social determinants of health because it's an important and relevant context for caregiving in Latino families. Social determinants like education, poverty, and access to care are associated with health status. And research shows that Latinos are more likely to do worse on these social determinants, even though they have longer life expectancies than the general US population. What this means is that on average, Latinos experience multiple disparities across their lifespans. And as they get older, these disadvantages start to pile up. So the result is poor health in old age. So while Latinos may be living longer lives, many are doing so with greater functional impairment, more illness, and greater severity of illness from conditions that are largely preventable, for example, like diabetes. As I'll show you in just a bit, this health and illness trajectory has significant consequences for Latino caregivers. And then another important context for caregiving is culture. And for some Latino caregivers, it frames how care is enacted within the home. I'm going to play a 2-minute video about Mexican culture. I hope some of you will recognize it and identify some cultural aspects that may affect caregiving.
Last night it seemed that I dreamed about you. When I opened my mouth, looking out was a song, and you knew every word, and we all sang along to a melody played on the strength of our souls, and the rhythm that
Okay, so what did you notice in the movie clip? In the video, we saw Miguel's intergenerational and extended family. We saw their social and emotional connections that they had with each other, their spiritual or religious beliefs about what happens to people's souls when they die, and the connection of those souls to the living. And lastly, the expectation of behavior. For example, expecting the entire family to gather to celebrate special occasions. So the movie clip is a great example of what the literature calls familism, a commitment to family as a structure, an idea that supersedes individual achievement, acknowledgement, and rewards in favor of the whole family unit. The family functions by norms of mutual assistance and reliance on each other. And if we were to watch the entire movie, we'd see that Miguel and his family all live together and work together in the family shoe business. We also saw Coco, the grandmother, and she was the center of the family. This is also an important cultural tenet according to the literature. In traditional Mexican culture, elders are esteemed and fulfill important social roles like socializing younger generations, providing leadership and wisdom in times of crisis, and transmitting cultural and familial knowledge. So in essence, culture matters when it comes to Latino caregiving. Unfortunately, the reality for many caregivers does not match the movie clip. As I mentioned, disadvantage over the course of one's life accumulates and can result in adverse outcomes as a person gets older. Because of this, many Latino adults experience illness and disease at earlier ages than would normally be expected, and more severe consequences from those diseases. So what this means is that some Latino adults will need help with caregiving at earlier ages. For example, Latinos have a higher prevalence of caregiving at 20% compared to the national average of 17%, even though the Latino population is younger on average compared to other populations. This also means that many Latino caregivers provide high-intensity care, which refers to how much care is being given and how much time is being spent on a weekly basis providing that care. The high burden of care among Latino caregivers also includes out-of-pocket expenses. According to a 2021 AARP study, Hispanic caregivers spend on average more of their incomes on caregiving expenses than caregivers in other population groups. The high burden of care that Latino caregivers face can lead to strain and burden or burnout from the stress of caregiving, the time and energy it takes away from other activities and responsibilities like work or family or pleasurable activities and hobbies, and of course the financial strain associated with out-of-pocket expenses. All of this can lead to poor caregiver health, which in turn then contributes to their own poor health as they get old themselves. And the cycle then repeats for the generation of the next generation of caregivers. So when we think about Latino caregiving, we must appreciate how a caregiver's lived experience meshes with the assumptions about Latinos and caregiving that we get from movies like Coco and from the academic literature. So I'm going to share one such story. It's Olga. I met her. She was a caregiver for her parents and lived with them for most of her life. She had no kids. She had never been married. She was 50 years old and born and raised in East Los Angeles, and began caring for her mother 10 years prior to the interview when she got diagnosed with Alzheimer's disease. And as we talked in the interview, we touched on the consequences that caregiving has had on her life, and this is what she says.
Dr. Mendez-Luck, are you able to turn your audio up?
Does that help?
No, the audio is not very clear.
You can't hear the audio?
No, not much. So you might want to go to advanced share settings, and there you might be able to do that. Or if you want, I can try to do it for you.
Okay, I don't know how to do advanced share settings.
Okay, let me go ahead and share my screen, and let's see if that helps.
Okay, great.
Question? Oh, well, I was asking you that what were some of the things that you gave up, because you said you gave
okay.
up some
Well,
things.
so yeah, life. I don't have a life. My life is my mom.
What was your life before?
Um, um, when, when I felt like going somewhere, I went. If it were a local gathering with a friend or two or three, or even a movie. If I didn't have to ask anybody for permission. I just did. Being single, travel. I love to travel. I can't afford that. Not only can I not afford it, but I cannot. Who do I leave my mom to?
So hopefully you heard that. And if not, you could read or follow along with the transcripts. And do I need to reshare my screen, or are we still sharing?
Yes, you can go ahead and share your screen now.
Okay, great. Okay. Okay, let me go to the next one then. Okay. So unfortunately, Olga's story is not unique. And there are millions of caregivers out there in similar situations as hers. So what can the federal government do to help Olga and caregivers like her? So the government could give Olga more help, right? So like homemaker services, personal aid services that can ease some of the load for Olga and improve the quality of life for her mother, Rosa. In actuality, the federal government does provide services that could supplement care through the Older Americans Act, through Medicaid home and community-based services, and a program of all-inclusive care for the elderly, the PACE program. In the interest of time, I'm not going to go through each one of those, but I'm happy to answer questions during the Q&A. And then second, the government could also just give Olga and her mom more money to purchase care or stabilize their shaky finances. Like, for example, we can give Olga credits or deductions on her federal income taxes to keep more of her money in her pocket. The government could also give her Social Security credits for the time spent as a caregiver, so that will help her meet the requirements to collect Social Security later in life. Another way the government could do is to pay caregivers to provide care. And in fact, Rosa was participating in that program because the state of California has that program in place. And then the government could then reimburse caregivers for their out-of-pocket expenses. Third, the government can provide services to Olga to minimize burnout, like offering a workshop on coping strategies for dementia caregivers, or providing respite time for self-care. The government does provide these services through the National Family Caregiver Support Program under Title III-E of the Older Americans Act. And so the government is doing some of these things and could do more. So these policies sound great, right? But unfortunately, there are inequities that are baked into these policies and inequities that are reinforced by those policies. So I'll start with the inequities that are baked in. Some of the programs I mentioned are targeted to individuals who meet certain threshold of need and income requirements which differ by state. What does this mean? Well, if a person doesn't meet the threshold of need, but still needs some kind of help, or has income just above the income requirements, The person is simply out of luck, and then so is their caregiver. Other programs like home and community-based services don't have an income requirement, but the OAA statute requires that funds be prioritized to individuals with greatest social or economic need. So depending on how much funding is available in any given local service area, you may receive services right away, or you may be put on a waiting list for those services. As of last year, there were over 800,000 Americans on HCBS waiting lists nationally. So this is an example of inequity baked into a policy. Now, these restrictions then determine who receives services and the range of services available, which in turn then leads to disadvantage for those who are either excluded from the policy from the start or who cannot benefit from the policy, even though they are not excluded from the program to begin with. All of this leads to perpetuation of inequity, some of which may have been caused by factors outside of the policy. So for Latinos in particular, there are disadvantages when it comes to language, immigration status, discrimination. Those are things that keep people from accessing services even when they meet the program requirements. This then creates further disparities for this caregiving population. There are a number of recent efforts to examine family caregiving policies with an equity lens. Most recently, the Administration for Community Living issued a report on a national strategy for family caregiving based on legislation that's been passed in the last several years. They are actually seeking comments from the public through the end of November. So I encourage you to go to the ACL website and exercise your voice, review those policies, and give your opinions on them. So overall, the conditions for addressing equity in caregiving policy are coming together, and there's been a renewed interest or attention to fixing the inequities in our society in general. So I'm optimistic about reducing disparities for Latino and other minority caregivers in the future, but I'm also realistic and recognize that policy shifts take time, so we won't likely see any discernible change in the short term. So in the meantime, what can we do to support caregivers? I feel like I'm preaching to the choir because we're all here discussing this issue today, but I feel obligated to at least have a slide on it as the politics of long-term care in Congress and in the nation get sorted out. So I'm not going to go into details. I think some of the other presenters have talked about some of these issues already. I think you know most of what's on the slide, if not everything, but I am happy to have further discussion after my presentation. I do want to point out that there are many different caregiver assessments that can be found online. They're a good way for a caregiver to determine his or her situation and decide whether or not they need more support. They can be taken in the privacy of their own home without having to wait for a doctor's visit, and then certainly give that information to the doctors so they can have a conversation with their providers. What's nice about many of these assessments is that they take between 5 and 10 minutes to complete, and they usually come with instructions on how to score them and how to understand the results. And this is just a few of many that are out there. Okay, so what does the future of caregiving look like? I would say that the policy landscape is complex. We have midterm elections coming up in a week, and all eyes are fixed on those races. So caregiving isn't exactly in the national spotlight as it once was during the beginning of COVID. But COVID did shine a light on issues that have long plagued caregivers and older adults. We're not done with COVID, but we're still dealing with the aftermath that the pandemic brought, such as increased anxiety and depression, feelings of isolation, changes in sleep patterns, increased alcohol use, and weight gain, not to mention coping with long COVID and the lingering health effects from having COVID. So these are issues that family caregivers will be facing for themselves, for their families, and for the persons that they're caring for now. The second thing to talk about is the economy. So, well, what can I say? The Department of Labor just released a report on jobs that showed that there was a slowed growth in new jobs. Inflation is at over 8%. Mortgage interest rates are at over 7%. And most analysts agree that we're going to have a recession sometime in the coming year. So what does this mean for Latino caregivers? Well, I already mentioned that they had high out-of-pocket expenses, so I would expect to see even higher out-of-pocket expenses and more financial strain for this population of caregivers that doesn't already have a lot of reserves in place. And then lastly, we can't forget the population trends that are occurring in this country. Not only is the US population aging, but it's also becoming increasingly diverse. In 2050, that's less than 30 years from now, the population projections show that Hispanics will account for 1 in every 5 adults aged 65 or older. So all of these factors make this this caregiving landscape challenging and complex. So as I leave you, I want you to notice that this 5 generations of caregivers in my family circa 1988, and I would like to end with a quote from Rosalind Carter. There are only 4 kinds of people in this world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. So in conclusion, caregiving affects every person and every family, and it really should be on the top of our nation's mind. And with that, I will leave it there, and I'm happy to answer your questions, and I really thank you for sharing this time with me.
Thank you so much, Dr. Mendez-Luck, and thank you to all of our panelists for your wonderful presentations. And now I would like to invite all of the panelists to turn your cameras on. And also, I would like to invite our audience to submit your questions. At this point, we would like to start our Q&A. And while you do that, if Dr. Johnson, if you could go ahead and turn your camera on.
The host is going to have to turn it on because the host stopped it.
Okay, I see. Okay. Let's see. Are you able to turn it on now? Perfect.
Yes. Yeah, I am.
All right, thank you. So I'll start with a conversation with a question for you, Dr. Johnson. So you briefly mentioned the research that you did a few years ago. And so you conducted a few focus groups to understand the cultural and spiritual perspectives that influence decisions about palliative care and hospice among African American church members. And then during that study, you began with the premise that African Americans underuse palliative care and hospice services because of a combination of factors, including faith beliefs. Could you talk about how cultural and spiritual perspectives influence the decision-making process of families when accessing palliative care and hospice?
Sure. Great question. This is a complex question because in addition to the faith and spiritual factors at play here, there are issues of distrust, there are issues of misinformation, there are issues of social and historical factors, and then there are family dynamics. And we found in our research over a course of 4 or 5 different studies that these factors all come together to influence decision-making in relation to palliative care and hospice. For one thing, in a study of deacons and deaconesses in a number of churches in the Philadelphia area, African-American churches, over 90% of the participants in the research thought they knew what the meaning of hospice was, but less than 50% actually even thought they know what the word palliative care means. And there's substantial literature about that too. And physicians use the word in palliative care a lot, and patient, and it sounds like apple pie and goodness all the time. So persons say they are receptive to it, but don't really know what it means. As far as the faith and spiritual beliefs, we hear statements such as "it's God's will," and there's a strong impact of those religious beliefs on the decision-making process. But then there are also contradictions that can sometimes overweigh those because of the other factors that I mentioned. For example, this belief that more is better, which is a reaction to deprivation in the past. I'll leave you with a quote that came from one of the focus groups, in which one of the recipients said, "We all want to go to heaven, but nobody wants a ticket." And that can be paraphrased as a contradiction to that person saying, "I believe that there's a good life. I want to go to the good life. The afterlife is great, but I really don't want to go there anytime soon, and I want you to keep me alive forever." The response of I think of us to that, caregivers and providers, again, is to talk about the good life in contrast to death, to talk about a good life being consistent with faith beliefs, and hospice and palliative care are venues for that good life. So I think one can find a way to bring the spiritual attitudes in line with services that can contribute to a good life.
Thank you. And that's a great way to begin a conversation. What type of good life would you like to live as you age? My next question is for Dr. Wu. Recently, I read that despite being the fastest growing minoritized racial group in the United States, and I believe you also mentioned that, Asian immigrants and Asian Americans are understudied in research on family and caregiving dynamics, especially during the ongoing COVID-19 pandemic. We have witnessed how the past 2 years have been very difficult for many family caregivers, particularly for the Asian American community. So how has COVID and the increase of racism and violence affected the physical and emotional health of family caregivers of older adults?
Thank you. This is a great question. Think about that caregivers are increasingly kind of afraid of going out, and afraid that the sense of anxiety under this kind of environment, afraid of going out because of for the concern of safety. And for example, that for caregivers use services, they may need to go out, they may need to kind of provide support. They feel the sense of increased the social isolation, particularly as our previous speaker was saying, that the sense of isolation, sense of insecure, sense of the concern of safety. That even not only actually think about caregivers, even we live in New York City, that as Asian Americans, that when we go out in the evenings, etc., my husband will be worried if we think about, be careful when you take a kind of subway, because that afraid of being attacked, because there's several kind of incidents happened in New York City, that the subway system, that Asian Americans was beaten for no reason, or just for being Asians. So these kind of things that certainly that create a lot of fear and the sense of concern, that has a huge, potentially has a lot of impact on individuals' mental health and the physical health as well. Also kind of in terms of affect the quality of care that they provided for persons with disability.
Thank you, Dr. Wu. And I think you brought up a really good point, that fear and what that fear does to the person, not just the patient or the loved one, but also the caregiver when they have to go out and buy groceries or take them to doctor's appointments. So I think it's important that we talk about this because often we just tend to relate to what is our immediate surroundings and not so much about what other communities are facing. So thank you for sharing. And my next question is for Dr. Mendez-Luck. So last year, you gave this wonderful presentation about elder caregiving in Latino families. And you mentioned, and you also mentioned it today, that although the Latino population has a higher life expectancy than other adults in the population, they age with more morbidities and burden of disease. Could you talk about how the social determinants of health, such as education, poverty, and lack of access to health insurance, are going to influence that aging process, and specifically the caregiving experience?
Yeah, sure, thank you. So as I mentioned in my presentation, the social determinants of health, like education, poverty, and lack of access to care, are directly related to health status. And the effects of these factors on a person's health kind of accumulate over a person's lifetime. So when they reach old age, all of those disadvantages that they had over the course of their lives kind of accumulate and can result in physical impairment and infirmity. Okay, so for Latinos, what this means is that they are at risk for acquiring preventable diseases like diabetes, for example, at younger ages. So they, because of that, then they will live for a longer period of time in their lives with those diseases, if not for the rest of their lives with those diseases. So what all of that means then is they're going to need care. They'll need care likely at younger ages. So that brings in caregivers at younger ages to care for them. And over time, that just takes a toll on the caregivers. So if you're taking care of somebody who's very frail or infirm, then you're more likely to be providing much more intensive care and spending a great deal of your time providing that care. For example, the caregivers that we talked to in our research studies, they were really caring for some very ill family members, and so having to give their insulin shots, having to do dialysis at home, all of these very difficult and highly clinical, really, services for their older adults that they were caring for. So because of that, it becomes a high intensity situation for many of these caregivers. And so that's what we see in some of the research studies about this idea of high intensity, high burden of care for Latinos. It just translates into a really difficult caregiving experience for many caregivers.
Thank you. Thank you so much for that. And I would like to invite everyone in the audience to please submit your questions. We actually have a couple of questions that have come in, and this is for the three of you. Would you like to actually says would love to hear more from our panelists about how caregiving and care receiving manifests differently for men in these diverse communities. What is important for us as professionals to know about?
Can I make a comment about that? And the first comment I'll make is that one of my references is to a book called The Hidden Among the Hidden, African American Male Caregivers. It's a fantastic, great introductory chapter, followed by interviews of 13 or 15 men in the Philadelphia area who are male caregivers. So what we know about African American male caregivers is that one, they're underreported for lots of reasons. That's true of male caregivers probably in in any ethnic and racial group, but certainly for African American caregivers. But they do have some tendencies that could be modified. One, compared to women caregivers, they are less capable and attentive to their self-care. Two, they have this more likely have an isolationist, go it alone attitude instead of seeking support groups and other and working with other family members. But I think there are venues where we can try to modify that, working with organizations in the communities, like churches, but also like fraternities. Also, I think for the health professionals, in direct response to your question, I think recognizing that one, African American males will embrace caregiving and often embrace caregiving. They need education, right? So all of us talked about skills and knowledge that needs to be in part. That should be one of the roles of the health professionals, to provide some of that education and communicate more effectively themselves too. I think there's a literature and my own observation that African American men have a low threshold for feeling disrespected by health professionals. And to the extent that the health professionals are more respectful in their communication, that is going to make that interaction with them more effective.
That's great to know. Dr. Wu, would you like to go ahead?
Yes, male caregivers are very common in Asian American population. I'm being kind of more in a general term, but in Chinese culture, there's a traditional saying, say, raising son for old age, right? So that certainly that as a particular oldest son, that you are responsible for taking care of parents when they get older. So, but in reality, that certainly has some kind of division of labor, that maybe men are more likely to take kind of financial responsibility and the medical decision-making versus for their daughter-in-law actually potentially provide more care in terms of instrumental, in terms of support for their aid, like making kind of meals and provide all kind of physical kind of support. So there's certainly kind of division of labor, and the daughters are also more likely to be involved. But certainly there's some kind of gender, the different expectations, medical decision making, that I would say that in the general kind of term, that males are more likely to make these kind of decisions, medical decisions overall.
Thank you. Dr. Mendez-Luck, would you like to go next?
Sure, thank you. So, in traditional Mexican culture, women and men have different social roles, according to the literature. But we see that is evolving and reflecting more of some of those broader social trends that we see with men and women in our society. And so having said that, I really see that our focus in research in general, but also in research particular to Latino cultures or Latino populations, that men are often overlooked. Even though they provide in general 4 in 10 caregivers are male in this country, so they're often overlooked. I think they're unsung heroes in caregiving, and we don't give enough attention to the needs of men, because we've been so focused on the needs of women because they've predominated in caregiving historically. But that is changing, like I said. In my research, and this is a very small N, right? So a very small sample, we did interview men right? To find out, well, how are they different in caregiving in terms of their cultural beliefs and their orientation to that role. And what we found was that many of them shared very similar, if not the same, cultural beliefs as women. And so where we would think, oh, well, maybe they're not going to do this kind of activity because that's quote unquote would be considered a woman's activity. We really didn't find that at all. That they had the same level of commitment and wanting to care for and do many of the same different types of support activities to help whoever they were caring for in their family, the same as women.
Thank you so much. That's I think is very important. I think that you mentioned something that we forget, and yes, the majority of caregiving is done by females. There's also a large portion that is done by males, and we really need to acknowledge that and look at our systems to see where we can change and help. So we have another question, and this comes from the audience. It says, I met a woman who worked full-time in an assisted living facility as a CNA. And then she went home to be the primary caregiver for her older parents who lived with her. So basically she left everything. Is this common or is it unique for each culture?
I will just, if I can start, I will just say I don't have a lot of information on this, but we do know that CNAs and those type of health professionals tend to be women and people of color. And so it would not surprise me that this is a situation that occurs more often than we think about, that they work in these type of jobs like a CNA or like working in a nursing home, for example, and then they come home and then they have to do double duty with their own family members. That doesn't surprise me.
Dr. Johnson, would you like to go next?
Sure, I would just try to complement what Dr. Mendez-Luck said by pointing out that double duty, that 24 hours of caregiving is clearly going to add to the stress of persons who do this. In this case, we're talking about certified nursing assistants. I mean, that's a job that is relatively low paid. And so one has that stress, and the financial burden of caregiving is significant. It's a significant one. I mean, one of the challenges for male caregivers too is often the men have to relinquish significant amount of their income in order to perform the caregiving duty. So, although clearly women do also. So exactly, it would be tough. I think that the take-home message for all of us though is that 24 hours of caregiving is a major challenge. It would have to be a major, just the emotional stress of doing that, aside from the physical stress.
Thank you.
Right, so that I agree with our panelists the feedback in a way that regardless what kind of a job that you have, that if you have family responsibility, you just got to fulfill the responsibility. So that's what certainly women are more likely to kind of share the family caregiving responsibilities, and the women in these kind of caregiving roles, whether it's a paid caregivers or unpaid caregivers kind of role, that they just have to do what they need to do. So that's what this is, yeah.
And it's important, I think, to understand that, because some of us come from different cultures, different countries, and this is very normal. And I think it's very different to the mainstream culture that tends to be a little more individualized. And so there is also that, I guess, that shock when you meet two cultures that one tends to do one thing and then the other one now has to kind of adapt to the new ways, and how do you navigate that? So, and for some people it's, yes, you do what you have to do to care for your loved ones. We have another question, and it says, could you provide some ideas on how a caregiver can request assistance from other family members? The burden falls typically on a few family members and not all the siblings. Do you want to go ahead and start, Dr. Johnson?
Yeah, sure. I think all of us who are in the clinical arena see this need all the time, that there is usually one person who does most of the work. I've always been partial toward that person. But then there are other family members who may actually have more influence when it comes to decision-making, may control the funds, and those, and then the sicker the person becomes, the more stressful the illness experience becomes for the whole family. There's no simple way to answer the question. What I try to recommend, and tried to point this out in my presentation, is to anticipate the need for these communications to take place over periods of time instead of just waiting for crises to occur, right? I mean, that's the worst time to try to talk about a feeding tube and whether or not, I mean, just getting all the members of the family together to even have the discussion takes time. So if there could be structured support groups, I think certain issues are predictable, like feeding is predictable, kind of resuscitation decisions can be predicted. There are predictable decisions that the main caregiver should suggest that there be a family meeting to just have a discussion about it. But don't wait until the crisis occurs to have the discussion. Try to have it in advance.
Thank you. Do you want to go ahead, Dr. Mendez-Luck, and do you have any suggestions?
Yes, sure. I agree with Dr. Johnson. It's best to have these discussions before a crisis actually hits, because that's when people are generally acting at their worst, or at least it can bring out the worst in people, not that it does. But it's really hard to have conversations. And I recognize, I have to say up front that I don't think I have a really good answer to this, other than to the extent that you can have conversations ahead of time, both with the person receiving care and what they would like to see happen and who they would like to see helping with what aspect of their care. That is important, as well as bringing in all of the family together to discuss it. Because it's very interesting that not everyone will come together and have a similar solution, and there could be some conflict around that really does need to be resolved, ideally before those crises points come to play. And so I think to the extent you can have those conversations ahead of time, and it could be around advanced directives, it could be around just very simple, this is how I see, like, what do you want, Mom, in your life, moving forward? And how do you see that playing out? And what do you see our role as? You could frame it that way. That way, all the children can hear that and then go from there. So it's not an easy situation at all.
Right. So think about in kind of in a caregiving setting that most often you have a primary caregivers, regardless how many siblings you have, how many children you have. It's always kind of often fall into one person who takes a major responsibility. But on the other hand, there's many kind of secondary caregivers that can be. But most often, if you are married, your spouse probably is a kind of by default to some extent take major responsibility. But it's interesting when you look at the immigrant population that most often sometimes can be adult children that make kind of as potentially decision makers that to provide, because U.S. healthcare system is very complex and sometimes it's disjointed. That to navigate healthcare systems is a very complex task. So that, for example, for immigrant kind of families, adult children may be more kind of in a better position and be more familiar with healthcare systems, that they may actually can have a more say in that sense. But on the other hand, this is a physical demanding caregiving jobs, and most likely potentially fall into spouse if you're married or significant others. So that's a kind of things that I think that is in immigrant caregiver families as a very, very complex kind of structure, and potentially also families kind of conflict can be evolved, because you certainly have people may have very different views that related to kind of acculturation, familiarity with healthcare systems, and the different cultural background. So within the one just a family, that many things can happen. Yeah.
Absolutely. Well, thank you so much to the three of you. And I have my last question before we end. So regarding the populations that you have studied in research, how has the use of the stereotypes, either positive or negative, influenced the access to healthcare for minority older adults in these different groups? Who would like to start first? I'm not going to pick on you.
I'm going to let someone else start first since I've been. Would one of you like to start first?
Sure, I can start. Certainly, this stereotype of Asian populations, we know that Asians have traditionally been kind of coined as a kind of model minority. But that stereotype is certainly misconception, that certainly the huge heterogeneity within the population. And when you look at the Asian Americans, their poverty rate actually is the highest among all minority populations. That I have statistics to show that. But when you look at the Asian Americans adult population overall, that they may have a higher socioeconomic, higher income. But for older adults, this is a very different kind of picture. And also when you look at many kind of surveys, national surveys, this can be for those English as with limited English proficiency. These older adults are most likely to be excluded from these kind of national surveys. That's why that you will kind of portray this is a very kind of picture incomplete for older adults that we see for Asian Americans. So these kind of stereotypes that can potentially prevent people and say, oh, you know what, they're doing great, they don't need help. So that actually is potentially very harmful, this kind of view towards many, many vulnerable older Asian Americans in the country. Thank you.
Thank you, Dr. Wu. Would you like to go ahead, Dr. Mendez-Luck?
Oh, sure. So a couple of things. I think provider stereotypes, that they have for their Latino patients does a couple of things. Affects their treatment recommendations, and then also can really affect the dynamics between the patient provider bond and or affect their communication. So I would say that the Latino patients who perceive that the healthcare provider doesn't understand them or respect them, that they're likely not to access a service again or follow recommendations of the provider. Latinos, we also know that Latinos are more likely to receive a lower quality of care than their white counterparts. So stereotypes are harmful not only to accessing care, but also the quality and type of service that they receive when they do access care. So I think it's an important thing to think about how we can improve that so that Latino older adults don't lose out, and can really benefit and maximize their experience in a clinical setting.
Thank you.
Sure. I'm not sure when we think about unequal treatment, which is well documented across populations, I'm not sure that stereotyping is the dominant reason for unequal treatment when I think about African Americans. I mean, there's disrespect on the part of providers. There built-in financial barriers to good health care and preferences, for example, for taking care of persons who are of a higher socioeconomic status. There's a structural racism that is embedded in healthcare systems and healthcare delivery in the United States, and those things lead to the kind of unequal treatment that was documented in the unequal treatment report by the National Academy of Sciences. But there are two specific areas, particularly regarding African Americans, that do come to mind that are stereotyped. One is pain treatment, where it's documented in the literature that health professionals have often undertreated African Americans experiencing pain because of a bias that they're not really having pain, they're overstating their pain, and that's been shown in a variety of age groups. That should be easily correctable too, just better pain control, consistent with best practices, and that's a documented stereotype. Another one that has to do with communication is assumptions that African Americans are not smart enough to understand medical language if it is converted and spoken in plain language. And so this is more of an observation than something I've read in the literature, but I listen to health professionals talking to African Americans and often don't hear them explain sufficiently and adequately what they're doing, what they're proposing, as they would with other groups. And I think one of those assumptions is that the person either don't need to know, are not deserving of the time, or cannot understand because they're not smart enough, which is a stereotype, of course.
Well, at this point, I would like to come to an end for our program today. And I really want to thank all of you, especially our panelists, for being here with us, for taking over an hour and a half of your day to be with us. Thank you so much. And it's what an honor to have been able to share with you this space. And to everyone in the audience, to all of the family caregivers, thank you so much for being with us. We hope that this presentation was informative and it will help you in your caregiving journey. Thank you so much, everyone, and don't forget to fill out our survey, and have a wonderful afternoon. Bye now.